Delighted to be here. I want to thank Jean for inviting me. Jean is right. The first time I gave this for the fellows was kind of a stroll down memory lane, and it seemed to me that I could use this as an excuse to update my own talks and to update you folks in a real way about what's going on sort of at the leading edge of the field. I was asked to put this talk together for another purpose just 2 weeks ago, so it's still maybe a little bit rough, but I thought this is an area as we start talking about and thinking about trials in NASH. I thought that endpoints for trials in cirrhosis in particular were worth thinking about. So what I'll talk about is just a little bit of general stuff about NASH and fibrosis, but I really don't want to steal the thunder from our new faculty who are building their interests around NASH. And you've heard a bit about this already, particularly from the Science in the City course a couple of weeks ago. Talk more about cirrhosis, current FDA guidance, functional endpoints, and structural endpoints. And the real issue here is that as we develop more and more drugs for liver disease in general, for NASH in particular, and for cirrhosis beyond that, we need to think about how we measure whether a drug is working. And what I'll tell you at the bottom line is this is very much a work in progress. In fact, I was just on a conference call with the Liver Forum yesterday, and there is no agreement at all about how one should assess efficacy of drugs in patients that are cirrhotic regardless of etiology. So this is really as much a thought experiment and to get feedback from you as it is an update. Some general review slides. Many of you have seen these already. Just to remind you, when we see fibrosis, regardless of etiology, I don't know why the drugs is a black arrow, but the bottom line is NASH has become, the driver of drug development in liver disease, owing to the tremendous success in developing effective antivirals for Hep B suppression and Hep C cure. So one major company has already withdrawn their program and antivirals for Hep C, and I think we have more than enough drugs. So it's really on to the next big challenge, which is NASH, and it'll become clear to you why that is a big challenge in just a minute. I'd like to remind folks that the liver is very unique because we manage patients who have diseases that smolder, often without symptoms, for decades. And then ultimately that culminates in cirrhosis, which, as you know, can lead to either hepatocellular carcinoma or the need for liver transplant from either cirrhosis or carcinoma. I'll get into the NAFLD epidemiology in a minute. Just to remind all of us that hepatocellular carcinoma is the fastest rising cancer, has the fastest rising incidence of any cancer in the United States. It's already the second or third leading cause of cancer mortality. I'm proud to say that many of you in the audience and certainly many in the institution are part of an NCI-funded liver cancer program, which is the only one in the country devoted solely to understanding and treating this cancer and no others. Just to remind you, NAFLD is a series of diseases, or an umbrella term. It starts with steatosis, often called NAFL, non-alcoholic fatty liver. This is not a state of disease where anyone is proposing treatments, not yet. And so most people are focused on steatohepatitis, depending on the stage of fibrosis. I don't think I'm talking about it here, so just to remind you, the way we I would say assess the severity of NASH is using the NAFLD activity score, which is comprised of a semi-quantitative scoring for ballooning, lobular inflammation, and fat. And we're still learning which components of the NAFLD activity score are more important, but bottom line is right now we think it's ballooning, but none of them are more important than cirrhosis, than fibrosis, which of course is ultimately the driver of cirrhosis, and the risk of hepatocellular carcinoma, which I'll get back to in a minute. Prognostic implications we've talked about quite a bit. Patients who have non-alcoholic fatty liver disease, whoa, that's great, have a 3% risk of cirrhosis, whereas those that have NASH with fibrosis have a 30% risk of cirrhosis. Yeah, I like to refer to the Greek term purus, which means hard. So this is where all the attention is focused. It's patients who have some element of fibrosis, and I'll tell you why in just a second. Of course, NAFLD arises not by itself, but in the context of this extraordinary epidemic of obesity. This is the kind of data you can get from the CDC website. It describes the number of states with percentages of obesity ranging from 0 to 9%, which are no states left, really starting here with states that have 20 to 25% of the population, that's Colorado, California, these New England states, and Hawaii, ranging up to states that have a population prevalence of 35 or greater of obesity, and that includes Arkansas, Mississippi, and West Virginia. And these are tracking the obesity rates over time. Some really stunning statistics that were reviewed in a recent paper by Bariatric and his group predicts the short and intermediate term impact of this obesity epidemic. Currently, it's believed that 65 million Americans now have non-alcoholic fatty liver disease. That will rise to 100 million by 2030 unless something happens. Of those, at least 16.5 million now have NASH. This will rise to 27 million. So even conservatively, this is 5 to maybe 6 times as prevalent as Hep C. And these are the patients who are at risk for liver disease. And like in Hep C, where we used to think that very few patients progressed to cirrhosis because we were predicting that in 1990 when the virus was first discovered, I think so too in NASH. We're at the early stages of an epidemic where the ultimate likelihood of progression to cirrhosis, cancer, end-stage liver disease is going to be higher than it currently is, because the epidemic is surging now, just as there was a surge in advanced Hep C over the 1990s and 2000s that led to more progression to advanced disease. So clearly a problem that's now caught the attention of virtually everybody, with the exception of the CDC, and a number of us are working to try to get the CDC to identify NASH as a discrete challenge that requires its own epidemiology and its own tracking. This is a recent paper from Laura Turow and others that underscores the impact of this epidemic on liver transplant, looking at the changing contribution of NAFLD to the overall wait list, as well as the prevalence of decompensated cirrhosis and hepatocellular carcinoma. So what you can see is from 2003 to 2015, a rising fraction of the wait list is comprised of NASH, a rising fraction of decompensated cirrhosis, and not surprisingly, there's a lag, but clearly a trend towards an increasing fraction of patients that have hepatocellular carcinoma due to NASH. So the future is clear. And what's interesting is that of all the features that I mentioned about diagnosing and staging non-alcoholic steatohepatitis, by far the only one that's strongly predicted is the presence of fibrosis, and that's shown in this recent meta-analysis from Rohit Oba and his group, looking at the rising mortality rate based on the fibrosis stage and the mortality rate ratio. So basically, the more fibrosis over time, the more likely there are to be clinical events. Now, one of the challenges in this disease, completely different from Hep B and Hep C, is this is a systemic disease. And so one of the things that we're challenged with, and when we think about drugs and we think about endpoints, is the competing comorbidities. And what we really want to do is identify the patients whose proximate risk of illness or death is from the liver disease component, even though the majority of patients with NASH, 2/3 to 3/4, will actually die of cardiovascular disease as they have NASH. Now, there's an argument to be made, which I won't get into today, that if we treat NASH effectively, we will have a carry-on benefit and attenuate the risk of other cardiovascular and other comorbidities. But that has not been established yet. So now let me start focusing a little on cirrhosis. As I mentioned, for those who came a minute or two late, virtually all clinical trials, with the exception of 2 or 3 out of the dozens, are focusing on non-cirrhotic NASH with fibrosis. But increasingly, if we're really going to rescue people, we want to have drugs that are effective in cirrhosis. And that begs the question of what do we measure? And the short answer, again, is we don't know yet. But this is from a thought piece that I wrote along with John Iredale, Lupe Garcia-Tsao, and Massimo Pinzani now several years ago, where we tried to sensitize the community to the fact that just because a patient says in a biopsy that it's F4 cirrhosis, it doesn't mean that fibrosis is stopped. It just means the system you're using to measure it has maxed out. And that's a problem, because if you look at all these patients that might be considered F4 cirrhosis, and I'm not going to go through this in detail, all of these patients would be considered F4 on biopsy, and yet there's a big difference between those that are compensated and those who are decompensated with ascites, variceal hemorrhage, and encephalopathy. And so as we think about cirrhosis, we also need to think about using more discriminating tests than simply a biopsy that says, yes, it's stage 4. Because stage 4 can have a perfectly stable prognosis for 5 to 10 years, or it can have a precipitous decompensation. And that's underscored here. This is based on work from the Baveno system. I don't know if it's explicit from their guidelines, but basically the portal hypertension gurus separate the disease of cirrhosis between compensated and decompensated, and that's pretty self-evident to the clinicians. No varices or ascites, varices, no ascites, ascites and varices, and bleeding plus ascites, and of course the outcome and the morbidity and mortality as you advance, and the risk of death goes up precipitously. And of course, most of those changes are attributable, if not all, are attributable to portal hypertension. So just to remind you that it is the contractile activity of both stellate cells and possibly endothelial cells in the short run that may restrict blood flow, but in the longer run, it's also the impact of accumulating scar that leads to dense nodules and thickened septi. And so these are data from a very simple and lovely study from Lupe Garcia et al., looking at the relationship between histologic features of cirrhosis, meaning the septal thickness and the nodule size, and the likelihood of a rising HVPG. And so what this is showing is, let me extract from this and say that what we're seeing is as cirrhosis progresses, the bands get thicker, and they squeeze and make the nodule smaller. So whereas when I was a fellow, everybody did a lot of hand-waving about how this disease had micronodules and this disease had macronodules, I think in current framework, we think it's more likely that the nodule size is related to the severity of the cirrhosis, meaning more thick bands. And so what you can see here is as septal thickness increases based on histologic staging, HVPG goes up. And as nodule size gets smaller, large to small, yet again, HVPG goes up. And so this, you could argue, might be one way to stage, but of course it's terribly, not so much subjective, but semi-quantitative and prone to sampling variability. But it is worth reminding us that that portal hypertension can be correlated with histologic parameters. And of course, at the microvascular level, there are dramatic changes in vascularity, distension of some blood vessels, disorder, and increased fibrosis, and increased shunting ultimately as well. So how do we measure that more quantitatively? Hepatic venous pressure gradient has been around for quite a while. Just to remind you, it's effective for those who know cardiovascular disease management. It's the Swan-Ganz catheter of the liver. You're effectively using a balloon catheter that is fed by the radiologist, and that's a side point. In this country, virtually, basically one unit in the country has hepatologists doing HVPG, and that's at Yale. Everywhere else, it's radiologists. The quality of the studies can vary. The standardization can vary. And studies that have tried to use HVPG as an endpoint not only have to have extensive training at their sites to do the procedure properly, but all the tracings that were generated had to be sent to a separate reader, mostly Jaume Bosch in Barcelona. So it's a very cumbersome test, but it does give us useful information, and it establishes a benchmark between measurable portal hypertension and clinical outcomes. And so this is again a study from Lupe and her team, along with many others, as part of a beta blocker trial that was negative. And effectively what it showed was that if the HVPG in cirrhotics is less than 10 millimeters, and those patients are followed over 8 years, is less than a 15% or about a 15% chance of decompensation. Whereas these patients, at the onset of which have a greater than 10 millimeter HVPG, they have somewhere around a 70% risk of decompensation. Now the challenge, of course, is number one, we don't want to be doing HVPGs on everybody. And number two, these patients are indistinguishable clinically. Of course, if you do endoscopy, you may see varices, which will indicate that the patient is in this group. But we still need better non-invasive markers of portal hypertension. So the other element that I want to introduce before I get into the hard potential endpoints is this emerging recognition that even cirrhosis can reverse. These are the best, and not the first, but probably the best data that establish that if you treat the underlying disease, in this case hepatitis B, you can affect a dramatic reduction in fibrosis and in the fraction of patients who have cirrhosis. This was a very large study from, it was actually multiple units, I think all in Europe, looking at the impact of long-term treatment with tenofovir on the fibrosis score of patients who were biopsied at baseline 1 year later and 5 years later. And among the cirrhotics, who comprised 38% of the population at the outset, with good long-term viral suppression, only 12% remained cirrhotic 5 years later. So 2/3 of the patients, more than 2/3 of the patients, have regression of cirrhosis, and this is exactly what Andrea talked about in one of her talks about a month ago in Hep C. So the number, remarkably, in trials, and I'll show you in NASH in a minute, about 2/3 of cirrhotics can actually regress. And there's a recent study that came out just a day before yesterday that I'll share with you that begins to suggest how likely it is with patients who have portal hypertension. And that's shown here. So this, I'm still trying to digest this study. It's a very meaty study. It just was published in the Gastro that showed up on my desk on Monday, but I wanted to include it because it's really the best study that I'm aware of that looks explicitly at the impact of an SVR on hepatitis C associated portal hypertension. These were patients who were already very advanced. They had child's B cirrhosis on average, varices, a number of clinical complications. They were assessed for HVPG and liver stiffness 24 weeks after SVR. A couple of things are worth noting. Again, very advanced patients. In aggregate, there was a significant decrease in HVPG, but the mean HVPG overall was still in the portal hypertensive range. So these are, as you would predict as a clinician, these are patients who still need complete monitoring and are at risk. The second thing is for those patients who had greater than 10 millimeter portal pressure or portal wedge pressure, 78% had remained having significant. So in other words, 22% of the 100% of patients who had portal hypertension, 22% did not have clinically significant portal hypertension. And actually, that's more than I would have expected. So you have patients who are already child B cirrhotic, they're cured of Hep C, and 22% of them have a reduction in portal pressure that's such that they're no longer significantly portal hypertensive. Of the 78% who had an HVPG of greater than 12 rather than 10, 63%, and of the 60, it went from 78 to 63%, and of the patients who had an HVPG of greater than 16, really patients who are at significant risk for variceal hemorrhage and mortality, 25% of the 41%, or 57 out of 93 patients, still had clinically significant portal hypertension. But the other way to look at this, which is fascinating, is that let's see, this is 36 patients out of this group no longer had clinically significant portal hypertension, even though they had an HVPG of greater than 16.
You know, it looks like as the portal pressure goes up, the percent that have a reduction increases.
Yeah,
and I think we see that in FibroScan too.
Huh.
That if you look at the change in FibroScan as a percent as opposed to an absolute number,
right,
the higher the FibroScan, the greater the percent reduction. And I think what that's saying is that when you have very high FibroScan, and I'm guessing it's for this too.
Yes, but there was no correlation in individual patients.
A big component is edema and that's what takes it very high.
It's a very good point.
So that's why.
I would subscribe to that as well. Now, a couple of other points. So just to reiterate what's in panel A, over 24 weeks post SVR, HVPG decreased from 15 before treatment to 13, which the investigators feel is very significant. It persisted in 78% of patients. I showed you that in panel B. And HVPG response was less likely as the MELD worsened. So remember, MELD isn't always correlated directly with portal pressure. Now, they looked at liver stiffness measurements as well, and they looked at the likelihood of improvement in liver stiffness measurements if the starting stiffness was 13.6 kilopascals or less. And you can see that most, but not all patients had a decrease, but most remained in the portal, or at least I'd say about half remained in the portal hypertensive range among the 24 patients. Here's what's interesting. Andrea's going to love this. 37% had an increase in HVPG despite SVR. And as she mentioned, and as Young Min had reviewed in a review we wrote last year that Andrea cited, there is a subfraction of patients with Hep C who do not get better histologically, and they may get worse. And it's arguable what the reason. Do they have concurrent NASH, or is there something immunologic or unknown that predicts or drives them to advanced disease even though you've cured the virus? On a patient-to-patient basis, the correlation coefficient was poor between HVPG and liver stiffness. So you can't just extrapolate on an individual patient that stiffness necessarily correlates with HVPG, even though in aggregate it did. And clinically significant portal hypertension after SVR, clinically significant portal hypertension persisted after SVR in 91% of patients if baseline was greater than 13.6. So these are patients who are less. If it was greater than 13.6. So I guess you could say if the patient has a FibroScan score of 14, 15, 16, there's a 9 out of 10 chance they're going to have persistent portal hypertension if these data are extrapolated to other settings. Okay, let's return to, let's focus in a little bit more on NASH. These are data that I think we've seen a number of times from our good friend Philippe Mathurin and his team, who are now focusing quite a bit on NAFLD and NASH, and they look specifically at the impact of bariatric surgery on stages of NAFLD, both in terms of activity and fibrosis, at the time of bariatric surgery and 1 year later. And so at the time of bariatric surgery, this is the distribution of disease, and then 62% had relatively advanced stages of NAFLD activity. 1 year after, NAFLD activity score now higher values are shrunk to 7.1%. We've seen this exactly the same in Hep B, which is within 1 year of effective treatment, inflammatory scores go down precipitously. And what happens to fibrosis? Well, it goes down too, but the fraction of high fibrosis stages goes from 32.5% to 23%, nowhere near as dramatic as the shrinking of the high-end group for NAFLD activity score. And of course, they are following these patients, and we hope and anticipate they'll do 5-year or 3-year biopsies in this cohort as well. And the prediction, of course, would be if the patients maintain their weight loss and otherwise are therapeutically benefited by bariatric surgery, this fraction of high-stage fibrosis will continue to go down over time. So, and we see fibrosis reversibility. We still don't know exactly why fibrosis reverses in some patients and others it does not, but these are some potential reasons, and I'll go through them quickly. We do know that the longer the injury, the more sustained the fibrosis, the more cross-linking, or put the other way, the more acute onset, the more likely there is regression. So for example, fulminant hepatitis will stimulate all the fibrogenic signals that are present in chronic liver disease, but if the disease passes either from a treatment of acetaminophen or Hep B clearance and immunity, fibrosis, chronic fibrosis is rare, if at all, in acute or fulminant liver disease. Secondly, we think the cellularity is important. So the more cells you have, that's good news, because presumably some of those cells are inflammatory cells that are a potent source of proteases that will degrade scar. A big issue is cross-linking. So the more cross-linking, the more insoluble, and there are different molecules or enzymes that cross-link collagen. One of them, lysoloxidase 2, was the focus of an intense therapeutic effort by using antibodies to lysoloxidase 2 to try to treat fibrosis, cirrhosis, and pulmonary fibrosis. None of those trials showed benefit, and that was several trials by Gilead. People who are committed to this mechanism argue that the reason that it didn't work is because the antibody wasn't potent enough and it didn't get to the site of the lysoloxidase. And there are companies, one of which we're working with, that has a small molecule antagonist to lysoloxidase 2, which they believe will be more penetrant in getting into the tissue and will have an antifibrotic benefit. The thickness of the fibrotic band. So I showed you that study, the histologic study from Lupe, and it reinforces the idea that the thicker the septi, the more inaccessible those scar fibers are to proteases combined with increased cross-linking. And so there is this balance of proteases and inhibitors that is very critical. Even if you have high protease activity, there are a whole family of inhibitors, and if they're as high as the proteases, you can have all the protease activity in the world, but your inhibitors will keep it from being activated. And one of the critical things that was discovered many years ago by John Iredale, primarily in his group, was that one of the features of highly activated stellate cells is they make a lot of one of those inhibitors called TIMP1, or tissue inhibitor metalloproteinase 1. And so one of the rationales for clearing activated stellate cells is that you can remove an important cellular source of that TIMP1. You pull out the TIMP1, you now disinhibit and activate those metalloproteinases that can degrade scar. And in fact, One of the earliest approaches that I'm aware of in trying to treat fibrosis was through a monoclonal antibody to TIMP1. And for reasons that I don't understand, it was abandoned by the first company that developed it, even though the rationale is still as strong as it was 15 years ago. So now let's talk specifically about the issue around endpoints, and I'm going to share with you what we know, and particularly what the FDA is telling us. So this is from the FDA website. The easy things are to measure, the easy and perhaps the most important things to measure in patients who are cirrhotic is death, need for transplant, decompensation events, hepatocellular carcinoma, and a MELD score change of greater than 2 points, or a MELD increase to greater than 15 in a population. So these would be considered hard endpoints, but this is obvious. This is the low-hanging fruit. Trials certainly want to be powered to detect an improvement in these endpoints, but they'd like to know before then whether a drug is showing any efficacy. So as many of you know, there's a group that has been organized. I was quite involved at the beginning, and I've pulled back just because it's very time-consuming. There's something called the Liver Forum, which is an all-stakeholders group that has now met 7 times at each of the EASL and ASLD meetings going back 3.5 years, in which we get in a room with regulators, that's EMEA and FDA, hundreds of companies now, because it keeps growing, obviously a lot of academics like me, even patient groups and advocacy groups as well, to sit in a room and say, can we come to some agreement on how to design clinical trials for NASH? And this model for consensus building around trial design was developed by the same people when they were trying to accelerate drug development in HIV in the 1990s. And the woman, Veronica Miller, has now transitioned that whole infrastructure first to study Hep C trials, which she did over the last 10 years, and now focusing intensely on NASH. It's a very successful model, and it gets everybody on the same page. It's been so successful, now the FDA is asking Veronica to develop similar study groups around PSC, which has been created already, as well as other liver diseases. And they're saying, whoa, you know, we can't do everything, but let's focus for the time being on NASH and on the PSC, but there's also alcoholic liver disease, drug-induced liver disease, etc. And the point here is that, as you see in point 3, not all cirrhosis etiologies are the same in terms of trial design. Or let's put it this way, Laura Dimick-Santos, who's our FDA contact, sort of speaking, thinking out loud, said, we don't really assume that any patient with cirrhosis with the same portal pressure has the same prognosis and the same outcome if one has NASH and one has viral hepatitis or PBC and so forth. So I think the one thing everybody agreed on is it would be risky to do a trial in cirrhotics where everybody, where patients have different etiologies. She's also pointed out, which is of course to me obvious, child Q TERCOT is not acceptable. It includes subjective measures. And so you'll never see trials where the child Q score is an endpoint. And one other point that she raised, and these are directly from Lara's presentation at the Liver Forum last month at ASLD. She doesn't know if different manifestations of portal hypertension are the same in terms of endpoints and response to therapy. In other words, is a patient who has predominantly varices more reversible than a patient who has predominantly ascites or hepatic encephalopathy? And of course, we don't know that. She also said they have no problem with digital pathology, and I'll return to that in a minute because it was an abstract from Zach Goodman that starts to use digital pathology instead of ordinal scoring. Other things she said, what's the best way to stage cirrhosis? They don't know. Compensated cirrhosis secondary to NASH in all clinical trials should include surrogate endpoints, and I'll talk more about that, as well as evidence of clinical benefit if they can. The challenge is if you do a small trial in patients who are 10 years away from getting cirrhosis or developing cirrhosis, you're never going to be able to power that trial for endpoints that are designed to show an improvement in clinical outcomes. Because even if the trial is 5 years long, if they're 10 years away from getting cirrhosis, you won't see clinical outcomes in anybody practically. So it's unclear the best way forward now. Some companies like Intercept have actually designed their trial to run for as long as 6 years, with the expectation that if the drug is effective, they will capture an improvement not just in histology, but in reduction in clinical events, HCC, and need for transplant. There are a number of hard clinical outcomes that are listed here. I'm not going to go through that, except to say that remember that all clinical trials, the FDA is charged with approving drugs that improve how a patient feels, functions, or survives, and that includes feels. So how a patient functions and feels have to be part of any aggregate endpoint compilation for a clinical trial. If a patient feels worse and their biopsy is better, FDA is not going to be very enthusiastic about approving that drug. And of course, functional status is a critical point, as well as the factors on the left that are more self-evident. So as I thought about this, and this is just my own construct, so I wouldn't say this is the party line, but there are really two large buckets to think about in assessing cirrhosis. One are structural endpoints, and you'll see what I mean, and the other are functional endpoints. And I've been pushing the field as much as I can, and now along with more and more people, to say, look, let's wait a minute. Just because we're a specialty that grew out of pathology, that doesn't mean that every trial we have to do has to be yoked to pathology. The liver has so many critical functions that can be quantified and measured and tracked over time, and that probably correlate as well or better with outcomes than histology. Maybe we should be thinking about functional outcomes of the type I'll say in a minute. So let's start with structural endpoints. Bottom line, as I said a couple of times, is fibrosis is the key endpoint linked to outcomes in NASH. That was shown most clearly when Arun Sanyal, our good friend, reported data from the simtuzamab ASK1 trial at EASL last spring, or this spring. So I'll show you more about this later, but it was a trial that was intended to use this LOXL2 inhibitor antibody, simtuzumab, with or without an ASK1, which is an intracellular kinase. And it turns out the simtuzumab didn't work at all. So every group that had simtuzumab plus the ASK1 inhibitor could effectively be viewed as the effective ASK1 inhibitor alone. And I'll show you a graph about that towards the end. So here's some very interesting things, because this was targeted at more advanced patients. It was a short trial. It was 6 months. And after about little over 2 years, 25% of the patients who had NASH and bridging fibrosis, non-cirrhosis, had already progressed to cirrhosis. So that's a lot. In effectively a 2-year period, 1 out of 4 patients who was pre-cirrhotic became cirrhotic. After a median follow-up of 26 months, 20% of cirrhotic patients had liver-related events. So if you already have a patient with cirrhosis, there's a 1 in 5 chance they'll decompensate over just a 2-year period. Again, this is effectively a natural history study because these are the simtuzumab patients alone. So we're effectively looking at the natural history in the presence of an ineffective drug. Now here's the part that I think is really critical, is given all that we've built around this NAFLD activity score, it turned out that NAFLD activity score had absolutely no predictive value in predicting who would progress in terms of fibrosis. And I think part of that, and I have a slide I didn't include here, is that the NAFLD activity score is a little bit of it oscillates a little bit. It can go up and down a little. There's sampling variability. It's the fibrosis that represents a more direct, integrated readout of the sum total of necroinflammatory activity, which may not be fixed in one point in time. And of all the things, fibrosis was the primary determinant, disease progression, and an acceptable surrogate endpoint in NASH trials. So I mentioned digital pathology. That just means taking a liver biopsy. We do this, my group in the lab is here, we do this all the time. We stain with Sirius red, which is a collagen-specific stain. We quantify the amount of Sirius red using a morphometric, a computer-aided morphometry tool. And there are different ones, and it really doesn't matter, but earlier studies looked at this very rigorously in Hep C. This was one of several studies, this one from Western Australia, looking at the collagen proportion area and determining how likely there was going to be endpoint-free survival. Bottom line is, the higher the collagen proportion area, the greater fraction of patients who had decompensating events. Likewise, the higher the collagen proportion area, the smaller the fraction of patients who survived. So the question, and when I had been to FDA with a company where we proposed in a NASH trial using digital pathology, they slapped us back and they said this has not yet been validated in NASH. You have to do it in NASH, you can't do it in Hep C, which in retrospect was perfectly right. So here's the early data from NASH. So these are data from that same simtuzumab ASK1 trial that were assessed by Jack Goodman, and I'll just go through this quickly. The higher the percent collagen or collagen proportioned area, the more likely there was to progression to cirrhosis. Optimal threshold to predict progression was 6.5% hepatic collagen. This is not far off from what we see in our animal models, which is somewhere from 2 to 6%. Among cirrhotics, clinical events increase with higher baseline percent hepatic collagen, but not Ishak stage 6 and 5. So to me, that's the critical issue here, is that predicting events is more accurate when you use this continuous variable of percent collagen rather than the Ishak 5, Ishak 6. So the optimal baseline percent hepatic collagen threshold to predict clinical events was 11. So patients had twice the threshold to predict progression. 11%, that's a lot of collagen, and that's telling you patients are going to be in trouble. Again, baseline hepatic collagen was much more accurate at predicting progression than Ishak, and it correlated roughly with liver stiffness by MRE and FibroScan. So now I think we can start to expect that if biopsies are performed and the biopsy length and size is accurate, that you will begin to see digital pathology proposed as one of the endpoints. Now let's also not forget about the risk of hepatocellular carcinoma, and I just put this slide in to remind us that this is going to be one of the endpoints that may either confound or inform our clinical studies of NASH. These are data from Helen Reeves. Probably nobody remembers Helen, but she was one of my first postdocs when I moved to New York about 15 or 20 years ago. She's gone on to do great things back in the University of Newcastle. And this is one of her studies that looked at the number of referrals to their regional center in Northeast England and the distribution of patients with hepatocellular carcinoma and the distribution of etiologies. And the yellow component of these bars, the orange component of these bars represents a fraction of patients who had underlying NAFLD as a cause of their, or as an associated etiology with their hepatocellular carcinoma. So it's, as of 2010, which is of course many years ago, over a third of their HCCs were NAFLD. Here's the part that's really, I would say, striking. 30% did not yet have cirrhosis. And this is almost identical to data that's come out in a VA population from Hashim El-Sarrag. I don't remember if he presented it last spring, but it tells us that reliably NASH gives rise to cancer at earlier stages, or is more likely to give rise to cancer at a non-cirrhotic stage than in Hep C. Hep C, the number is 16.5% based on the Halt C data. Here it's 30%, and Hashem's it was, I think, 35 or 36%. So it means we need to start thinking about HCC before patients are cirrhotic if they have NASH. They, of course, have advanced fibrosis, but they're not cirrhotic. So what are some of the structural tests that we can use to capture the change in fibrosis without having to do biopsy? There's been a technology around for quite a while called liver multiscan, developed by a company called Perspective, which is in Oxford. This is actually using a standard T1 weighted MR image, but they have a proprietary algorithm. They put the data in there, and they can generate what they call a liver inflammation fibrosis score. And most recently at AASLD, they showed a study that looked at the impact on the liver inflammation fibrosis score following DAA cure of hepatitis C, something we talked about, and Andrea was very involved with using a diagnostic from a company called Kinemed. So what you can see here is the color changes dramatically. The liver inflammation score goes down. There was one patient in whom the lift score went up. I don't remember the interval exactly. 24 weeks, sorry. 24 weeks after SVR. Now, one patient whose lift score went up was ingesting 120 grams of alcohol a day. So this may be one kind of test. Whether it's sensitive enough to tell us that fibrosis is regressing and disease is improving, I think remains to be seen. Another is the MR fat fraction. This was a trial presented at EASL a year ago, or earlier this year, looking at fat content and showing that in response to this particular drug, a recombinant engineered FGF19, there was a dramatic change in liver fat at both doses of the drug compared to placebo. It's a very confusing graph, but the bottom line is here, MR fat fraction can be a very robust endpoint if your drug is expected to reduce liver fat. So, companies can't just say one size fits all. You need to choose an endpoint, whatever the stage, that corresponds to the expected mechanism of action of your drug. MR elastography, I would say right now, has the most data, the most robust findings, and I guess we lost that, sorry, and a high area under the receiver operating curve, particularly for detecting cirrhosis. So of all the tests, I would say MRE is by far the most sensitive and specific for distinguishing cirrhosis from non-cirrhosis. Again, is that enough? Is there enough of a dynamic range from pre-cirrhosis to cirrhosis to use this as an endpoint over time to assess response to drugs? Time will tell. Now, I already mentioned my bias about let's think about functional endpoints. So where are we with that? I already showed you this graph in a different form that HVPG predicts clinical deterioration. You could consider this either a structural or a functional endpoint. But there are others that we should rely on that really beg or hearken, I guess, to what pulmonologists have been doing for years in pulmonary fibrosis trials. When they're testing whether a drug improves idiopathic pulmonary fibrosis, they never rebiopsy the patient if they have a diagnosis. They look at FEV1, forced vital capacity, 6-minute walk test, and they correlate with outcomes in response to therapy. One way is MELD, and this just illustrates that MELD less than 10 is associated with low short-term mortality. And this is a slide that Arun put together that he shared with me, that at least thinks through the idea of whether MELD could be an endpoint in cirrhosis. Does it reflect mortality? It does when it's greater than 14. Does it reflect decompensation risk? Well, it depends, because greater than 14 already are decompensated in many cases. Can it be considered as a surrogate for organ death? And the answer is yes. So certainly any study that's looking at outcomes in MELD, cirrhosis, is going to collect MELD data. Whether MELD data will emerge, or MELD change, delta MELD, or MELD itself will be viewed as a primary endpoint, I think remains to be seen, but there's certainly tons of data about the impact of different MELDs on clinical outcomes. But there are, in fact, a lot of other functional tests. I'm going to review a couple of them here. One is collate clearance, another indocyanine green, which I haven't included, another is methacillin breath test. So this is a test developed by Greg Everson, who's a well-respected hepatologist at University of Colorado. And what he's developed is a test that looks at the comparative clearance of collate based on whether it's administered IV or administered PO, which represents portal vein. And so particularly if there is shunting, some of the labeled collate is shunted and the clearance is different. And so he's done great studies, and this is, I think, from the HALT-C population, long-term treatment of hepatitis C with alpha interferon, and it showed very nicely that that what he called his DSI, discriminant, I don't remember what SI stands for, correlates very nicely with outcomes across a very large range of DSI, in at least 52 patients in this case. And recently at AASLD last month, he extended that. He modified the test so that it's a single point in time, showed in a modest number of patients that it may actually also still be useful. And they call this now HepQuant stat, because it's a single point test rather than multiple time points over time. And it showed an area under the curve that was quite, I would say, impressive, and decent sensitivity and specificity, both for diagnosing NASH and diagnosing NASH with varices. So again, another functional test that many companies are including as a secondary endpoint to see if it can predict those who respond. Another test that we've known about for a long time, and actually did some studies probably over a decade ago from a company in Israel called Excellence, has something they call the breath test. Patient drinks a substrate, a clear liquid that has non-radioactively labeled methacillin. Methacillin is normally degraded by the hepatic microsomes, and what it yields is a small amount of acetaminophen that's not toxic, and C13 labeled CO2 that one can capture in a nasal prompt. And so what you see is the excretion through the nasal breath of C13 labeled CO2 over time. The rate at which it goes up and the overall magnitude and area of the curve is a reflection of the underlying metabolic or microsomal function. And at least in early studies, there was some correlation with MELD. More recently, they've generated data that I don't know if this has been shared with me. It is public. I don't know where it's been presented. But what they showed in this cohort of about 20 some odd patients, I think 23 patients, is that compared to HVPG and transient elastography or FibroScan, after SVR of hepatitis C, this was the only one that could clearly distinguish between patients who had elevated tests and those who had a response after cure of hepatitis C, compared to HVPG, which suggested that all patients still had clinically significant portal hypertension. Now, of course, the question is, what's the outcome of these patients long-term, and which is more robust in predicting clinical events? Is it, in fact, the methacillin breath test? And again, time will tell, and the company is doing studies. The final approach that I'm extremely intrigued about, both because of its cleverness and also because of the talent of the founder of the company. This is work done by a company called Glimpse, which was created by Sangeeta Bhatia. Sangeeta's been here a couple of times. She's absolutely brilliant. Actually, she just won a major prize. She was elected to the National Academy of Sciences this year. She's basically a biomedical engineer, MD, PhD, who has a large lab at MIT. And what she created with her team was a platform in which patients are administered substrates that are labeled with tags that can be detected by mass spectrometry. You administer the mix of substrates. The substrates are specific for all the different enzymes that might be relevant. I'll show you a slide in a minute. And you collect these cleaved substrates in the urine, and you can do mass spec, and you basically see different peaks that quantify the enzymatic activity for all the different enzymes and substrates that you're measuring. And what you get, as shown in this animal study, is you actually get a heat map that shows you activity of different proteases across different animals. And here it's just shown diagrammatically as well. Oh my God. That's weird. I don't remember what this says, but basically it's protease. What they're trying to do, which is the challenge in this test, is they don't quite know how different proteases relate to stage and function and outcome of liver disease. And so they're trying to bucket these different protease activities into those that might be involved in lipogenesis, inflammation, or fibrosis. Again, early days, but it is a functional test. It's measuring the universe of proteolytic activity that is present in a patient with liver disease. I think time will tell yet again. So let me just close by making a couple of points. Clearly, this is new territory, and it's been an incredible amount of fun, and I'm hopeful that we will be increasingly engaged in many of these trials because we're defining new biology here. We're really establishing a template for a group of patients who are in desperate need of effective therapies. So some things I think we can say already. I think most of us believe, and the FDA has made clear, that we can't yet lump cirrhosis from different etiologies. We don't know if complications of cirrhosis all have equal weight or likelihood of reversibility. For drugs that need to be approved, there has to be a strong correlation with fibrosis and function, and especially clinical outcomes. And whatever test is used has to be reproducible, means if you do it on a different day at a different place, you get the same result. And it has to be scalable. And I think that's, to me, the death knell of HVPG. You cannot scale HVPG to do it easily on thousands of patients that might be enrolled, let's say, in a phase 3 trial that is required for drug approval. And then finally, I think the heart failure folks have already been thinking about this for a long time in developing a composite endpoint where they combine functional and structural information. And so I've given you some ideas about which structural and which functional tests might lead the pack and ultimately become part of such a composite end score. To me, the non-invasive tests with the most promise include the structural tests of MR fat fraction, which is now in these short-term trials shown really dramatic improvement in drugs that should reduce liver fat that are affected, MRE, and the lip score from perspective. I think among the functional tests, MELD always has to top the list because we know it so well, but also methacetin breath test, HepQuant, STAT, and the GLIMS platform, which I've shown you. But I'm not trying to favor these. There are lots of things out there that are being developed. Sort of stay tuned. This is very early days. Arun liked to say, and I love to quote him, we are in the NASH era equivalent to where we were in 1990, 1995 in treating hep C. That, in those days, we had monotherapy with interferon 3 times a week, made patients very sick, 5% SVR. Then somewhere along the line, the NIH group added ribavirin, trying lots of different combinations for the weakest of rationales. Boom, suddenly 35, 40% SVR. Then ribavirin was pegylated and went up to 50 to 60%. Then direct-acting antivirals, boceprevir and telaprevir, were added and went up to 75 to 80%, albeit with a lot of toxicity. And now finally we're at what we think is the end game, where you have multiple regimens of direct-acting antivirals, well-tolerated, 8 to 12 weeks, cures in 95+% in uncomplicated patients. If you use that as a benchmark, we're at the 5% cure with interferon days in NASH. So we have a long way to go, but I think I didn't review here some of the clinical trial data that at least tell us that we're really on the right track. Already there's evidence that some drugs will improve fibrosis, whether they can be sustained, whether it's potent enough, whether we need combination, and whether, most importantly, that translates into improvements in clinical outcomes. I think time will tell. So the next 10 years, 15 years are going to be a really wild and exciting time, and ultimately will improve patients' lives, and that's what this is all about. So I'll stop here so we can take time for questions. Thanks.